Hello, my name is Viral Verka, you can call me Vio. I have a little disclaimer to make that this presentation is purely informative and it is subject to my personal point of view. I do not represent anyone but myself. Some data information may be outdated as the changes happen faster than I can follow. I did my best to have the most recent changes until this date of August end of 2013 included. However, the ACA can be read by anyone at the US Department of Health and Human Services at hhs.gov website. My goal is to remove some of the confusion about the terminology, concepts, and semantics and to clear some of the mysteries, to give a clear picture of changes that are coming next year and how this whole concept will work. In 2010, the first draft of the Affordable Care Act came to life, followed by the Healthcare and Education Reconciliation Act. It became popularly known as the Affordable Care Act, or as Obamacare, how others would like to call it, or PAPACA. So we are at a good start. Even the name of the act could not be agreed upon. The most important changes are that more people should be now included in healthcare and pay for it too. Finally, insurance companies were required to do what they were supposed to do to insure America. The marketplace or the exchange are used interchangeably. They mean one and the same thing, so none of these names are great. This terminology is a bit deceiving, a politician's convoluted way of telling the truth. The marketplace is subsidized by the federal government, and subsidies are the money given to those who could not afford a complete payment for the healthcare coverage. The marketplace or the exchange is an elusive concept, and the slide shows who the stakeholders are in the exchange or in the health insurance marketplace, except for the federal government. This one is missing from the list because it is part of the exchanges. I intend to give a good picture of what is going on, not just to talk about a few terms which were repeated ad nauseam by many, but were really never understood. So since this healthcare overhaul is huge, no one person can know it all, and especially when the updates and changes are frequent and constant. There are many agencies protecting the insurance companies. I will not name them here. They are irrelevant for this presentation. However, the National Conference of Insurance Legislators is one of them. Only the government is protecting the insured and the customers of these insurance companies, and somewhat. Insurances are private businesses who pay lobbyists to protect their interest, and their money is well spent. The results are right here in the front of us. Many cried that American people are coerced into higher taxes to pay for it, while others that Americans are being forced to buy insurance. Well, this may be true. What was the alternative? More of the same. Whether people have insurance or not, when in need, they will require care, and they will receive it. Therefore, it shall be their responsibility to pay for it. If they do not have the money, the rest of us will have to cover the cost, which is the cost of goods sold, already sold. And we do that by declaring losses or paying for the healthcare costs with our tax money. Now, insurance companies raise the cost each year as a rule, sometimes by double digits under the pretext that they too cover losses. The reality is that direct care providers incurred losses from those who could not pay, which they wrote off too. Now, those with high copays who cannot pay them transfer their risk to the providers, not to the insurance companies. And while insurance companies collect the money, hospitals and doctors' offices suffer the losses. Unfair as it may be, no one does anything about it. That is an example of corruption in the system. As a sideline, IRS is complaining that it already has too much work from the Affordable Care Act, but too little power to enforce the rules. And it's true, but to help the IRS, the government wants to create two new agencies. So NCOIL cried that states will lose their power, that these agencies now will create some jobs and will also spend some of the healthcare money. We're at a good start, at least, at employing now 5 people to observe, guide, pay, verify, and train the one who works. Senator Breslin is a legislator with the NCOIL, and he's one of the 5 in there. His announcement was indeed a surprise that insurance companies exist to provide assistance and mitigate the cost of maintaining our health, not to reap massive profits by denying us coverage. Please allow me a short Business 101 reminder here that just like any other business, insurance's final goal is profit. I will repeat, insurance's final goal is profit. It is not and never was to keep the people healthy. The interest is to collect a lot of money, give some as health coverage back, and pocket the rest. various businesses have various ways of achieving this end of collecting the money from the many to funnel it to the few, and without providing anything in return, it would be impossible for them to do so. Therefore, each business sells something. The money spent on customers while collecting the customer's money is the cost of goods sold, a necessary evil for businesses. But whatever is left is profit, and profit goes in private pockets. More money directed toward profit results in less goods sold and many times in lower quality. The cost of goods sold have various names. They implicate taxes, rules, regulations, which businesses lobby in their favor. Without regulations, businesses maximize their profits by paying employees little and offer consumers unfair goods. What is unfair? That is another topic. It is of philosophical significance, and a few slides in here will not cover it. Some people may argue that America is the last bastion of unchecked capitalism. Some love it, some hate it. Good or bad, it all depends on which end of the capitalism one is. Now, businesses, companies and corporations are into the business of using all available resources to funnel the money from the many to the few, and then sometimes commit crimes, intentional crimes. All kind. Hiding money, offering altered goods, poisoning consumers and the environment. They use deceptive marketing techniques, and there is no limit to what they can and do. Therefore, the governments must step in to protect the nations against these intentional crimes. Now, governments do a poor job at it because apparently they also benefit from these crimes, from lobbyists. They will have extra work to do. They win popularities by talking about these issues and elections. And yes, it all comes down to elections and the benefit of being elected. Here are two doctrines aimed at protecting consumers against corporate crimes. These two special govern insurance contract, the uberrima fides and caveat emptor. So, uberrima fides, that means good faith, complete disclosure, and the caveat emptor, that is the buyer beware, the funny disclaimers, the little tiny fonts that no one can read, and the fast talk on the radio and TV that no one can understand. It means in plain and simple English, I'll trick you if I can't, and now the insurance companies will have to part with this practice. Being wealthy and healthy is being at the good end of the capitalism, and fewer Americans are at that end each day. Now, wealthiest become wealthier, but not necessarily healthier, and at least the wealthier can get what America has to offer. Now, according to different economical theories and models, the people deserve some goods, but not all, because they live in certain society. Some argued that one should get what one deserves. Unfortunately, no one knows nor can calculate that value. For example, genetically inherited health and intelligence is not a personal contribution, but it makes all the difference. Winning the lottery, on the other hand, is luck, such as inheriting wealth. However, all citizens use roads and the bridges that are built with our tax money, common money, and everybody benefits from police protection and border patrol regardless of the contribution. So why should healthcare be different than this? Here are the 4 acts that were supposed to protect America against the corporate abuse. Now, they all failed, and still failed to protect the customers because corporate lawyers know their ways around them, and they find loopholes, or worse, the lawyers create intentional loopholes when writing them. There are 4 other commerce laws, for example, the Stark anti-kickback law, and the Stark law says that anyone who takes a bribe or a split or a commission or a kickback in exchange for referring services financed by the government, such as Medicare and Medicaid, gets 5 years in jail and or 50,000 fine. Now, Pete Stark, the man who wrote it, wants it repealed now because the law has evolved on its own. It has about 35 exemptions and bars doctors from investing in healthcare business. These 4, the Sherman Act, this one regulates trade and commerce by preventing unlawful restraints and price fixing, monopolies. This should promote competition and encourage the production of quality goods and services at the lowest prices. The Clayton This one prohibits the suppression of free competition by making illegal for business prices discrimination, exclusive contracts. It also regulates mergers and acquisitions. The Robinson patent limits the ability of large, powerful buyers to gain price discounts through the use of their buying power. McCarran-Ferguson states that the states have the authority to regulate the business of insurance unless the federal law specifies otherwise. It relates mostly to the regulation and taxation, but do they sound familiar? Are these among the complaints that made the Obamacare happen? And absolutely, there is more. And there is the other part, the one that cannot be regulated, because businesses do not want to go where there is no money, which is natural. And it's logical. But according to Stansel Harvey, the CEO of the Delta Regional Medical Center in Mississippi, tens of thousands of uninsured residents in the poor area and most rural parts of the Mississippi may be unable to get subsidies because no insurances will go there. That is the part where healthcare as a business model shows its inadequacies. There are many parts in the US lacking both insurances and providers, and in these parts everyone is looking at the government to do something. Now, lowering the taxes may not be sufficient nor the adequate approach. Now, if you pass this responsibility on the federal government alone, and without tax money, the government must borrow to pay for its expenses, and everybody complains about big government. Insurances do not want to go where there is little money, but they do not want to spend the money on treatments either. So insurances had no trouble denying the care, and that was the common practice. Talking about deception, this summary addresses a majority of issues America has with insurances, and this list here is self-explanatory, and details are well described in the healthcare document. Now, in short, this says that there should be a good description of what insurance does for the insured, how much. It must be plain in simple words, and at least a lawyer should understand that, I think. But briefly, insurances beginning in 2014 can no longer deny coverage, cannot refuse to insure anyone based on pre-existing condition, and must spend 80% of the money they collect on paying for direct care. The cost-sharing part is spelled out. However, in the lower plans, the high-cost sharing is a subject on its own, because in the US, the procedures cost about 3-4 times more than in other places around the world. So insurances through buying power negotiate prices down. However, this is important because the higher prices, the higher the individual's participation, and many won't be able to pay that part. In fact, I expect that most of those who cannot pay a lot in the healthcare will be in these lower plans with higher participation. Now imagine the debt for those without the insurance, and the amount of the debt that it's written off by some providers, and they also benefit from these high prices. Now, for example, a hip replacement is $40,000. The insurance negotiated for $12,000, but the bad debt from the unpaid customer is written off as $40,000. Ingenious, isn't it? So this is how the insurance world is divided in 3 separate markets. Now, beware, 3 markets, not marketplaces, which is a term reserved for the subsidized health insurance marketplace. Try to make it simple. The federal government employees market is one place, private insurance market is something else, and the marketplace is for the subsidized. So I was inventive enough to create a new group I call the sliders, which temporarily may benefit from one or none of the 3. I know the terminology is a killer, so I had to add one more. But now, private insurances in private markets are separate, and private insurances in public markets are in the exchanges, which is the health insurance marketplace. So private insurances are in both markets. Okay, the Fed and the states required of these private businesses to qualify, which means they have to play by new rules, and just to be able to receive the governmental contracts from Medicaid and child insurance and protection and others. Now, the sliders are employees who lose jobs, they transfer from one place to another, they retire, or who knows, they may become uninsured. Some may follow on Medicare and others on Medicare. But for now, if they may buy in a private market, uh, if they become uninsured, perhaps Medicaid. That possibility of being unemployed still exists and will for many years. The jobs are unlikely to come back soon. And insanely, many companies cry that they do not have enough qualified employees, while millions of MBAs and PhD and technical and military retirees have no jobs. And I ask, how about qualifying them? How about training these people to become qualified? And another craziness is about that now employers found another justification for their erratic behavior, and they are focusing on the employees' engagement. Some researchers found that while the productivity in the United States per employed person increased to 2.5 times, the employees are still not engaged enough, and that this disengagement causes huge loss in businesses. They count that in billions of dollars. So, besides that, the findings and the hypothesis do not match with the reality and with other findings, so these economical philosophers could not even agree what the definition of the word engagement is. Interestingly, companies waste a lot of money on such research, and the consultants who come with innovative ways of beating around the bush are doing really well. The trend is not to employ more people, but to beat more on the employed. Contrary, in some European countries, many employees work now 30 hours a week to create more jobs and benefits for those who work with their participation instead of relying on governmental handouts. Now, here is part of the confusion that I try to clear out for you. The federally insured and the federally subsidized are in two separate groups. Americans and legal immigrants will fit into one of these categories I described in the previous slide. However, the ACA is about the uninsured, the underinsured, the underpaid, and those who are at some poverty level. And the division is because of the funding. So the subsidized, which is another word for the poor, in one group, while those who work for the government are in another group. Not all governmental employees will remain in the Cadillac here, how they call it, and some will have to go to the marketplace. Now that will be interesting to see how will the government subsidize its own employees. And I can already see the news titles, something along this line: poverty within the US, governmental employees rampant. So, some rules of the Healthcare Act apply to the insurances in general, but there are also special rules that are applicable to each market division alone. Till now, the individuals and small businesses were able to purchase insurance from private health insurances in the same way. So what's different? Several things are. However, the concept of private purchase remains the same. Some players, more or less, will stay in the same markets, and I expect that the established ones having significant market share and developed provider networks will remain there. The most important part is that the same insurance companies will now play by new rules, all of them. So insurances will have two markets to worry about, leaving aside the federal part. So the private markets where the money is, and the subsidized, the marketplace where the trouble is. And Aetna pulled out of 3 states so far, and I assume it was because of the marketplace. The marketplace says that they will be able to drive down the cost, to increase the competition, to give everyone the same purchasing power. How will this all happen? By what kind of magic? Because currently small businesses face premiums that are 18% higher than the large businesses. These also face higher administrative costs just to set up and maintain a health plan. Up to 3 times higher administrative costs are built into them as are in the plans in the larger group market. So the small businesses are also at disadvantage in negotiating with insurance companies because they lack the bargaining power. So, when I talk about the 4 acts, remember the Robinson patent, the one that limits the ability of large, powerful buyers to get price discounts through the use of their buying power. So, we already have this law. We had it for a long time, but it didn't work. In reality, it can never work because it is not logical. So more by definition is cheaper, and sometimes that comes also from the overhead cost, which is pure mathematics. Now, starting in 2014, small businesses with up to 50 employees will have access to the state-based small business health option programs, the shops, and exchanges are supposed to expand their purchasing powers. Now, the Congressional Budget Office, the CBO, stated that the exchanges will reduce cost and increase competitive pressure on insurance, driving down the premiums by up to 4% for small businesses. So my question is, why not by 18%? The difference, we'll see soon enough if any of this will happen. In the slide, we see the number of Americans at roughly 320 million, and some of the employers categories, they are not separated by who goes where in healthcare. It was funny to see this information from 2007 and how 120 million Americans had job, 1 in 3 people, including children, retirees, and everybody had a job according to this data. But this number would qualify for Ripley's book of Believe It or Not. Anyway, 35,000 million people who work for small employers will enter the marketplace, and some from those 70 millions from the employers who employ up to 200 later on. Look at the uninsured, they were 30 millions, and some sources found that the number was close to 50 millions. But remember, employers must provide coverage for their full-time employees, and according to the US Labor Department, the Fair Labor Standards Act, the FLSA, does not define full-time employment or part-time employment, and this is generally a matter to be determined by the employer. The full-time may be anywhere after the first 30 hours or 35 hours per week, which is most frequent. So, the Part-Time Work Convention of 1994 established that part-timers and full-timers must be paid equally, and that was also confirmed by the Lilly-Ledbetter Fair Pact of 2009. There was a lawsuit Goodyear in Alabama for the pay differences. Now, the health benefits, however, are another story. For example, the FLSA does not require vacation, holiday, severance package, sick pay, meal, rest period, holidays off, vacation, or any premiums to be paid for weekend and holidays, or pay raises, or fringe benefits, discharge notice, or the reason for it, or any payment as a final, or whatever. So these are perks, these are not rights, and employers in general offer perks only to their full-time employees, and I'm not sure whether the Affordable Care Act can change that in the future. It remains to be seen, but we can expect trouble from the employers and for the employers whose part-timers work every now and then double shifts and reach these hours in a week. Would employers be tempted to make these numbers as low as possible, to hire everybody part-time? I would expect many of them to cut the hours and increase the number of people on subsidies, because this way they will pass their employees on to the government and indirectly to all of us to subsidize them. Insurance companies must qualify for the marketplace, and they have to cooperate with the navigator site to enroll people in their plans. They have to bring together buyers and sellers of insurances with the goal of increasing access to coverage, and the qualifications are spelled out in the Affordable Care Act document. But once insurances accept the state rules and the Fed rules and sign the contracts, individuals will be able to find them on the state website. So after determining the eligibility in the data hub, the insured will be able to enroll in the appropriate plan, and the choice is to find an insurance and a plan from the offer, then learn about them and compare them to be able to make the choice, the right choice. Again, all insurances are private businesses, and now they are going to have two parts to worry about: the private market and the public market, the subsidized market. I will not comment on their functions, the private market is relevant to the exchanges. I just want to show another division of how that is set up. These people who are going to the program, they will apply online, by phone, or on paper. In some cases, they can mail their application. The eligibility of the program, however, will be established instantly with the data input, at least theoretically. And first, the cost-sharing subsidies are not the same thing as the healthcare low premium tax credit. So the data hub will connect many agencies online for immediate data access, and I will go into detail about this a little bit. The tax credits, they will pay into the monthly premiums, and people with incomes between 100 and 400% on the federal poverty level, whose employers don't offer affordable coverage and who aren't in Medicare or Medicaid and who go to exchanges to buy coverage, they will get this. In states that expand Medicaid, the eligible income for subsidies would be between 138 and 400% of the poverty level. Now, tax credits go to premiums. The cost-sharing subsidies, they go to out-of-pocket. They will apply to deductibles and copays to lower the total amount that someone has to pay for the healthcare in any given year. Now, the cost-sharing subsidies go to only to some of those eligible for the premium tax credits, but they must be enrolled in the silver plan. And what is important is that those with less income will get more money for healthcare from the government. Now, to add insult to injury, another term came to life, the AHBE, as we did not have enough of them, which is the American Health Benefit Exchange, that shall differentiate employers from individuals in the exchange, and it is SHOP employers versus AHB individuals. QHPs, the qualified health plans, serve both. Now, small employers are employers considering up to 200 employees, and therefore only some from this list of 5% will qualify for SHOPs. The rule for employees' numbers, percentages, and tax reduction based on participation in healthcare coverage will change every year, and that is a great material for another presentation. Now, those on the right side, the Medicare, the federal employees, and large employers, they will not be able to enter into the marketplace. I'm not even sure they want to, but Medicare, beware, because those in Medicare should not be tempted or lured to enter into the exchanges, as they will lose some of their benefits, and most likely they will pay a lot more. Alright, so this is the system at a glance. It starts with the individual who needs coverage or with the small employer. They will go to their state exchange or marketplace, to the navigator website, or call or ask any insurance agent who will direct them to one. They can apply online, phone, mail application, with or without help. Now, helpers and navigators, that is another issue. I will not cover that in this presentation. But once the data hub determines where the individual and the small business belong, the subsidies, which is the money for individual and tax reductions for businesses, will be shown, and at this point the plan is chosen based on the participation. They are all precious metals, and the more expensive are with less participation, but less out of pocket, I mean. And we'll see plans in another slide. Now, out of the pocket expenses stays even with the subsidies, and these pose a great risk for hospitals and providers and special cheaper plans which requires higher out of pocket. Some people will try to avoid paying for the healthcare insurance altogether, and many will be unable to pay, but also won't be able to join in Medicaid because states have no money to expand it or won't. So those who qualify for Medicaid but cannot be enrolled, would they have to pay the fine? Perhaps, but that is unlikely to be enforced. So, what will be collected in fines cannot even be guessed. Some did it anyway, and the estimate may be a little bit high at $11 billion. Here is the healthcare.gov webpage. This is a navigator, and it was released July 3rd of this year. The information is new, actual, and accurate, and I hope so. And That's what the navigator is. Most likely it's not going to be a person. The Data Hub, you perhaps heard that there are issues with the data because there are many agencies which should provide timely and accurate information to the hub for the instant determination. So here all the individual and business information should converge. Data Hub enables exchanges to determine if an applicant is eligible for insurance coverage from under federal programs. This is what exchanges must have and do. Well, first they have to inform millions of Americans about their choices, and the outreach and the education part is seriously messed up in here because there is confusion who does what, how they will be paid, how much, and what each must or must not do. Navigators are still in trouble because while it is clear that the systems are the navigators, they are confused with the assisters, with persons, with people who are going to assist. But in short, navigators will have assisters, the people who should guide the uninsured to the right insurance and to the right plan. So assisters come in different shapes with different names and purposes. So assisters may suggest but not choose the plan nor the insurance agency for the uninsured. Brokers and the insurance agents will also have many limitations in dealing with the private and public options too. And I know that there is a general confusion about the navigators, but this navigator craze is mesmerizing. Everyone and everything is a navigator. For example, in this one, there is a personal health navigator, and this one schedules doctors' appointments, most likely belongs to a health system. Here are two other navigators. At the top is the charity navigator, which will guide givers into intelligent giving. Perhaps guide to the charities who belong to their list on some kind of membership, and there's another health navigator. On this slide, we'll also see other navigators. So one healthcare navigator organizes transport that accompanies patients into the physician's room. On the top right, there is a law firm who helps patients navigate the health system. I'll leave it to your imagination how and why. And at the bottom is the Geisinger's medical home navigator. So just to mention, the marketplace assistance comes under all of these in one way or in the other. But for the navigators, especially, there is going to be certified application assisters, in-person assisters, still perhaps navigators. There will be licensed agents, brokers, and some are going to be paid, some are going to volunteer, and I'll have another presentation on navigators alone. So back to the exchanges, we see that there are all kind of things in here in the market. So we have the federal, we have the state, we have some hybrid, and we have the private ones. So the states were asked to take care of their own exchanges and to build one per state, but most did not. Actually, about 37 states left the feds to play the game alone. So where the state refused, the federal government took over, and they will now look alike under the guiding hand of the Health and Human Services. But why so many exchanges? Somebody might ask. It's because of the tax, the state laws. A simpler way and cheaper would be, since the federal government is subsidizing poverty anyway, would be a one federal exchange for all. In that exchange, the taxes could have been worked out. Now we will have 50 states exchanges plus the private ones. So we are fragmenting this more and more, and the private market has life on its own. It will function as it did before, except for the new regulations in coverage, such as the age, pre-existing condition, and other limitations regarding to charges and what will be offered. Here I think I made it really simple. So there are three separate worlds. The federal employees program is on the left side. The private exchanges are on the right side. And in the middle is the marketplace, the exchange, the health insurance marketplace, which is one per state. So now, there are three possibilities for each state, but only one exchange. So one possibility is that the state take care of their exchanges alone, absolutely subsidized by the feds. And the other two options are two partnerships. One is these partnerships are obligatory with or without states' cooperation. Now talking about the difference in between these two partnerships, so the state management is by the face because the states did not want to participate, but the state consumer is managed by the feds while receiving some form of cooperation from the states. Makes sense? A little at least, I hope. I can do nothing about the names. The whole act is plagued with this kind of confusing terminology, but at least we know that there are three possibilities for each state, but only one exchange or marketplace plus the private market. So these technical differences will not matter much for the uninsured or for the insured. They will have the options given by the QHPs for their states anyway. So now each of these states will have some of the different insurances in the marketplace which will compete for the customers. I have some doubts about how this competition will work, in special when many providers avoid Medicaid patients and now Medicare too. So the electronic health record, the EHR or the EMR, how some might call it, same thing, being outrageously expensive, complicated, will force some provider to stay out of the CMS altogether. Now, I believe that the EHR should have been made free to the providers by the CMS, who should have developed one of their own, because they are requiring it in special. So one EHR system may cost hundreds of millions of dollars, plus the lifelong maintenance, all the updates and the troubleshooting, and the reliability and the complexity and the functionality of the system is frustrating for physicians and causes serious losses for the hospitals during the implementation. Now, payments will be linked to the health savings accounts, and I personally believe that for the subsidized this has minor significance. Perhaps more so for those with chronic conditions who will choose higher plans and put aside more for the out-of-the-pocket expenses. Now, as you noticed, the same poorly chosen names because these, at least one of these savings accounts should be called something else. I don't know, perhaps personal health account or health fund account. But now each plan has specific rules about what can be done with the money and what can be spent, if it can be transferred, and that is not the topic, and I will not discuss it here and now. But what is important, these plans will and should be linked to the exchange. Now, every dime counts, in special when it comes from millions of people. When choosing the coverage, it's important to mention here that insurers will choose what plans to offer and where. And although there are 5 plans plus one for the catastrophic coverage, they are not really required to offer all the plans in every market or in every state. But each of them should offer at least one silver and one gold plan. Here are the 4 plans, and as I said before, the cost sharing goes to those in silver plans for the copays and out of the pocket. Now, these now have a limit, and once that limit is reached, the government pays for the rest. Now, the subsidies, which is the tax, goes to everyone who needs it and is in one of these plans. The coverage is pure metal, ironclad, even if at minimum, this is how good these plans are going to be. Yeah. Or not, because all the insurance habits die hard. Now, the catastrophic plan is also a possibility, and most likely some of the young and healthy people or those who lose jobs will buy this. Would be something along the Cobra lines. Whatever the plan is, it must offer the minimum coverage as it is written in here in the essential health benefit package benchmark. So because copays and out-of-pocket are here to stay, can expect an increase in both very soon. Inflation, the greater risk pool, more of the deal coming to the system, but not with money. So there is a whole set of regulation in that regard, and I won't spend time on that. Now, the hospital care is still expensive in that regards, and the instructions from the government is make a wise choice. It is all up to you. So if you have the money to make a good and a wise choice. The good news is that people can change within plans from the options given, absolutely. So since insurances won't give a lot, won't have all the plans, and the Medicaid doesn't have the money, and here is a report by Ravich and Volker. Ravich is a Democrat, a politician and businessman from New York, and Volker is a Democrat economist, ex-chairman of the Federal Reserve under Carter. And these guys did the research and found many things we already knew. But in short, we as a country are broke. There is no money in the banks, but on the paper, and in some politicians' imaginary funds, and even that is mostly debt. Now, for your information, the Federal Reserve System is considered an independent central bank. Therefore, there is nothing more federal about this bank than it is about the federal auto parts. The question of payment for the US healthcare already over 3 trillion and counting remains, leaving aside the governmental health burden for its employees. Now we're adding to that the Medicaid, the CHIP, the no taxes or less taxes, and even those are less valuable each year. All these have to be shared to more entities. So who will pay for this and how? Well, there is also going to be a great shift in the categories of the insured. Most of these who come to the system will come with the empty pockets, and there is some money coming from the participants, both the insured and insurances, but will that be enough? Will the unspent insurance money, which will now be returned to the customer, offset for some of these costs? The government bets that it will. At least one half of the government, or the left side of it, believes so. But the right side, well, they sided with the insurances and successfully managed to mess this healthcare bill up properly. Now, both Ravich and Volker paint our future in a very dark light, and yeah, low taxes for more than a decade, the outsourcing, the wars, the joblessness. Where is the revenue supposed to come from? Now, the financial accounting rules state that borrowed money is a liability, not a capital gain. So if anyone borrows money and then places in its in saving account, the money is not his or hers, really, until they pay back the loan in full plus plus the interest. So not long ago, the states could spend only the federal money for their Medicaid, and each year they would come back with the same unspent money. The rules change now, and the states must spend their part too, and each year come with a balance equal to their demand from the Fed. That is why states will not expand coverage now. So many people, many ill people, will be left out of the healthcare, and perhaps just a little less than before, or maybe it's just going to be a different category. But lower taxes did not result in an explosion of jobs, nor in the growth of the state fund. So perhaps doing the reverse might work better, changing the policies and the politics. Anyway, the Congressional Budget Office, the CBO, and the Joint Commission on Taxation, they came up with these estimates that $11 billion will be collected per year. So the government believes that it will get some money from the 8 million of the uninsured. Most likely the bet is on the young and healthy with jobs and income. But there are 30 million of uninsured, and they will still consume the healthcare without paying for it, and that is a very high number and a reason for serious concern. It's like nothing happens, nothing changed. The dark prediction at the bottom of the slide says that it might even not be true that we will collect any money, but that we will continue to witness an increase in debt, and perhaps a lot faster than before. So even if we collect it all, it's a drop in the healthcare bottomless sea of expenses. Everybody was talking about the penalties, and they wonder what they're going to be. Now, I mentioned that they might not be collected, but it is still a question. How will the feds find those with no money and who qualify for Medicaid but are not enrolled because the states do not let them in? So at least the illegal aliens, they need not to worry about any hardship from the feds in that regard. They can go to any ER for free as they did up till now. So perhaps the issues of the feds surveillance we hear about so much are just rumors, because I assume that they would be able to identify and deport the illegals. Since the healthcare is so expensive, the money lost from this one tiny issue cannot be insignificant. Then perhaps finding the solution to this one problem alone would pay for itself. To find the Americans and to pay for the illegals, I really see no logic in that. Looking at all these rules, we can say safely that the government made another law with no teeth to bite back. I find, anyway, this an act of incommensurable compassion and perhaps wisdom, indeed unexpected from our government, because whatever the intent was, what more can government take away from those who have nothing anyway? But before I end this presentation, I must say that many good things did happen, such as insuring students until 26 years of age if they are in school, and also some questionable changes happened too. However, the most important change that could make the difference did not happen. The middleman is still in there, a little tired and resting, but make no mistake, still sucking significant resources. Only 20% out of the $3.2 trillion spent on healthcare each year is about $640 billion, and that much goes on administrative costs and capital gains and never to come back. The insurances are still there. The patients still have no control over the prices, nor do they know the cost of their care, nor do they have to say anything in how the insurers contract with the providers and how they establish the prices together, nor do they have to say anything about the out-of-pocket expenses or any other participation. So, for most of the hospitals and providers, any competition is just an illusion and material for administrators to talk about, because most patients will still go to the closest place or where their networks allow them to. What issues can arise from all these exchanges and systems and the people who will now have to work together? Well, anything imaginable, I suppose, but nothing new at the personal level in regards to choice and responsibility. The data hub, that is another story. We can expect all kind of wrong codes and system failures. In fact, eHealth, an entity which contracts with the CMS, recently released a statement that the company cannot ensure that it will be able to enroll individuals in qualified health plans at the beginning of the initial enrollment period of the October 1st of 2013 or within any other specific time frame. So some are worried also about data breaches, which is nothing unheard of. Now, HIPAA does not have any control over outsourced billing and transcription services to a third world countries. Even in the United States, that the data theft is very significant. Actually, it was one of the leading causes of concern. But imagine what will happen when all our data and social securities and financial statements and everything is going to go to a third world country. And imagine a contractor having access to all the agencies, and all the people we never wanted to have our data now might. So will individuals be able to make wise decisions that in the manner that is expected of them? Will they understand the choices, the payments, the rules, the risk? And my question is, does it even matter? Perhaps at the poverty level, many will not, and many of those who could will not have enough money to place themselves out of the harm's way. So what are they going to do? And about the satisfaction with the plan, I would not blame the education or the intelligence for this part. No matter how intelligent one is, the choices are still measured in greenbacks. I hope that in this presentation I gave you a lot of information that would be useful to you, and I hope that you like this presentation, that I cleared some of the fog spread around by the terminology and the concepts. So my intent was to inform and to not just bore you with dry facts, which can be found in the healthcare document and in the thousands of associated pages with rules and regulations. So this was a community service, a civic duty, I would say. It's a result of my personal engagement into our common and social well-being. I thank you for your attention and have a very great day.